The goal of a vaccine is to induce the immunity that is a consequence of natural infection without having to pay the price of natural infection. That's what it is. And there's a variety of ways to do that. Ben Franklin, actually, in the early 1700s, when his 5-year-old son died of smallpox, he lamented that he had never variolated him. Now, vaccination was born in the late 1700s with Edward Jenner's smallpox vaccine, which was basically using cowpox to protect against an antigenically related human smallpox. And that was really the birth of, I would argue, modern vaccines. Worked then, he published it, and thus was born a vaccine, cowpox, which eliminated probably the biggest killer of mankind. You had probably 500 million people died of smallpox in the world's history. It changed European history. It killed monarchs. And now we haven't had a case of smallpox on the face of the earth since the 1970s. Now we're in the next era, arguably the fifth era of vaccines, which is you actually don't inoculate the person with a whole killed virus, or you don't inoculate them with the weakened form of the virus, or you don't inoculate them with a single protein of the virus. You inoculate them with the gene that codes for the protein. So now the person makes the viral protein. And that is the leap of the mRNA vaccines. You actually give the gene that codes for that. And so it's the genetic era of vaccines.
Hello, everyone. I'm Larry Weeks. Welcome to another episode of the Bounce Podcast. On this episode of the podcast, I'm discussing the history of vaccines, dovetailing into the current state of vaccination around the globe and here in the U.S. The biggest vaccination campaign in history is underway. More than 4 billion doses have been administered across the globe, enough to fully vaccinate 30% of the global population. In the U.S., we have about 356 million doses have been given so far. And so far, meaning mid-August 2021. My guest on this podcast is Paul Offit. Paul is a physician and is the director of the Vaccine Education Center at the Children's Hospital of Philadelphia, as well as the Maurice Hillman Professor of Vaccinology and Professor of Pediatrics at the Perelman School of Medicine at the University of Pennsylvania. He is the recipient of many, many awards. Last count, I got up to 18 or more of his awards, and they include the J. Edmund Bradley Prize for Excellence in Pediatrics from the University of Maryland Medical School, the Young Investigator Award in Vaccine Development from the Infectious Diseases Society of America, and a Research Career Development Award from the National Institutes of Health. He has published more than 160 papers in medical and scientific journals and in the areas of rotavirus-specific immune responses and vaccine safety. He is also the co-inventor of the rotavirus vaccine, RotaTeq, recommended for universal use in infants by the CDC in 2006 and by the World Health Organization in 2013. I cannot do his CV justice, so I'm going to ask you to Google him, look him up. I do want to point out a couple more things. One is, in 2018, Dr. Offit received the gold medal from the Sabine Vaccine Institute, and in 2019, the John P. McGovern Award from the American Medical Writers Association. And he was awarded the Edward Jenner Lifetime Achievement Award in Vaccinology from the 15th Vaccine Congress. Dr. Offit is also a member of the Advisory Committee on Immunization Practices to the Centers for Disease Control and Prevention, and is currently a member of the FDA's Vaccine Advisory Committee, and is the founding advisory board member of the Autism Science Foundation and the Foundation for Vaccine Research. So this is pretty much me asking Paul a few questions, filling in the gaps that I had as far as the history of vaccines in the U.S. and globally. So without further ado, here is Paul. Paul, welcome to the show.
Thank you.
Could you just give us and my audience, so that I don't make any mistakes, a little CV and what you're doing now and a little bit of background, a short blurb?
Sure. So I'm trained as a pediatrician. So I did a pediatric residency, but then I pretty much went into research and just worked for 25 years plus on trying to understand a virus called rotavirus, which is the cause of fever and vomiting and diarrhea in young children. That virus accounted for about 75,000 hospitalizations and 60 deaths every year in the U.S. because of dehydration. So we created the strains that became a rotavirus vaccine that was licensed and recommended for all children in the United States in 2006. It was recommended by the World Health Organization for all children in the world in 2013. So that's really what I am. I mean, I'm a sort of virologist, viral immunologist. I spent a lot of time in a small concrete blocked windowless room at the Wistar Institute on campus inoculating mice. Okay, that's basically who I am. More recently, in 1998, I was asked to be a voting member on the advisory committee for immunization practices, and that sort of gave me, and now I'm out of that mouse house, it gave me a look at the anti-vaccine movement, who were invariably present at those meetings. And it struck me that although there were a number of pediatricians who would stand up for vaccines, vaccines are bad, vaccine preventable diseases are bad, vaccines are good, I vaccinate my own children, but I didn't hear scientists doing it. I wanted to sort of see scientists. So we created the Vaccine Education Center in 2000. I started to write books about vaccines for the general public and about medical issues for the general public. And that kind of put me in the firing line of anti-vaccine activists. So I think they hate me. It's sort of, judging from my hate mail, the occasional death threat, I'm going with the notion that they hate me. But so that's it. I mean, I sort of went from science to what I thought was just going to be science communication. But once you sort of cross the line and take on people as personalities, in other words, pull back the curtain and say, look at the influences of these people, look who funds them, then it becomes politics. And politics ugly and mean. And so that's where I went. So that's kind of where I'm at now. One other thing, I'm also on the FDA's Vaccine Advisory Committee.
Well, thank you for coming on. And this is such a dire topic. I want to approach vaccines from a historical context. How time turned vaccination from purely, haphazard experiments to a highly refined science. And you're the man to talk to. So let's jump right into it. And I want to lead up to where we are now and maybe how we got here. Is the anti-vaccination, I hate to call it a movement, Paul, but that type of thinking, is it global, or is it concentrated in the US, for example, or?
So there's a woman named Heidi Larson, who's at the London School of Public Health, who runs something called the Vaccine Confidence Project. So she looks at countries across the globe to answer that question. I mean, which countries sort of tend to trust or not trust in vaccines? We're actually not the least distrustful or the most distrustful. The most distrustful is France, actually, in terms of vaccine confidence. We're better than they are. So no, it's certainly not a U.S. phenomenon. It's an international phenomenon. And even some sort of India, for example, has a large middle class, which can be anti-vaccine. So it's everywhere.
In trying to prep for this, I was reading of some history of 15th century China regarding smallpox. But how long ago did we start this process or discover it?
Well, you're right. I mean, you could argue in the 1500s, they did something called variolation, or at least something like variolation, where you would, when people would have smallpox, they would take the blisters and then dry them out, ground them into a crust, and then, inhale them or inoculate them into the vein. So it basically was kind of like a weakened form of natural wild type smallpox virus as a way to protect against disease. And that did work. I mean, it did have a side effect, which was you could die from that. But for the most part, it did work. And Ben Franklin, actually, in the early 1700s, when his 5-year-old son died of smallpox, he lamented that he had never variolated him. Now, vaccination was born in the late 1700s with Edward Jenner's smallpox vaccine, which was basically using cowpox to protect against an antigenically related human smallpox. And that was really the birth of, I would argue, modern vaccines, was in the late 1700s with the Jenner's cowpox vaccine.
Now, talking about vaccines and inoculation in a general sense, was it the observation of, hey, you could develop some immunity if you had the virus or if you had a little bit of the virus? Was that the observation back then, or?
That's exactly right. I mean, people knew that. So take Jenner, for example. I mean, Jenner noted that milkmaids in his employ, he was a physician working in southern England, and smallpox would sweep across the southern English countryside every 2 to 3 years. He noted that women who milked cows, when they would get these sort of blisters on their hands or on their wrists associated with those blisters that were on the cow's udder, this is just pure phenomenology. Nobody really even knew what a virus was then. But he thought those two things were connected, because when those smallpox would sweep across the southern English countryside, these women who milk cows were relatively spared. hence the term milkmaids have fair skin, because when you survive smallpox, you invariably had these residual pock marks on your face. And so then he did the experiment. He inoculated his 15-month-old son with essentially what we now know as cowpox, and then he challenged him basically with human smallpox, which is what variolation was, and found his son did well, that there wasn't a sort of a severe swelling at the site of that inoculation of human smallpox. And the little kind of study you have trouble getting through institutional review boards today, but worked then. He published it, and thus was born a vaccine, cowpox, which eliminated probably the biggest killer of mankind. Of humankind. You had probably 500 million people died of smallpox in the world's history. It changed European history. It killed monarchs, and now we haven't had a case of smallpox on the face of the earth since the 1970s.
His approach at some point hit its limit, right? Not every human disease has some kind of animal analog that confers immunity without causing the disease itself. Some animal diseases jump to humans and can be deadly for both, right? Like, in fact, COVID-19, I believe, right, can also do that.
Yeah, so the goal of a vaccine is to induce the immunity that is a consequence of natural infection without having to pay the price of natural infection. That's what it is. And there's a variety of ways to do that. One is to use an antigenically or immunologically similar animal virus. I mean, our vaccine, the rotavirus vaccine that we developed at Children's Hospital of Philadelphia, really uses at its heart a cow virus. It's a cow rotavirus. But, as is true with many mammalian viruses, species barriers are high. So a cow rotavirus will infect a calf and cause disease, but not babies. And, human rotaviruses infect babies and cause disease, but don't really infect calves or don't cause disease in calves. So there was just fortuitous when that occurs that you can do that. I mean, the tuberculosis vaccine is also that. The tuberculosis vaccine, which prevents Mycobacterium tuberculosis, that vaccine is Mycobacterium bovis. So it's really a cow strain of tuberculosis. But so those are really the only three examples where you have sort of an animal strain used to protect against a human virus or human bacteria.
Got it. So what was the next kind of milestone from Jenner as to vaccinations? Right.
So then so Jenner was late 1700s. So then you sort of fast forward about 100 years to Paris, France in the late 1800s. And that was Louis Pasteur, who basically took rabies virus that he had inoculated rabbits with rabies virus, that it was obtained from dogs that were dying of rabies. And then he took the spinal cords and dried them. As you dried those spinal cords, the rabies became more and more killed, so that when it was really dried over a period of 3 weeks, it was really dead virus. And then he inoculated that essentially into people to save their lives, because rabies is a vaccine that can be given post-exposure, because rabies has a very long incubation period, meaning from the time when you're first exposed to when you develop symptoms can be as long as 2 months. So there's plenty of time to develop an immune response which can be protective. So that's a vaccine that can be given post-exposure, the same way we give it today. And if you're bitten by a rabid animal, you get a rabies vaccine that will protect you from dying from rabies. So you went from sort of an animal virus, and then the next 100 years later, a whole killed human virus, rabies. So the influenza vaccine was made in the 1940s. It was made by taking influenza, growing it up in eggs, and then purifying it and killing it. Jonas Salk made his polio vaccine the same way. Take polio virus, grow it up in cells in the laboratory, and purify it and kill it. I would say the big leap was the yellow fever vaccine that was developed by Max Tyler working at the Rockefeller Institute. What he did was he took a virus which is strictly a human virus. Yellow fever only infects people, but he sort of adapted it to growth in animal cells in the laboratory, like mouse cells, chicken embryo cells, and mouse embryo cells. And by doing that, he was weakening it. So basically he took a human virus and he weakened it by growing it in non-human cells. And that became the yellow fever vaccine that we use today. And it was also that was the basis for how we made the measles vaccine, the mumps vaccine, the German measles vaccine, the chickenpox vaccine, one of the rotavirus vaccines were all made that way. And for which Max Tyler won the Nobel Prize. I mean, that was, you win Nobel Prizes generally for technological achievements. That was a major technological achievement, and it was made in the 1940s. 1940s, he made that up. So that takes you sort of through the 60s. And then you sort of move into the recombinant DNA era, where you use the same sort of technology that's used to, say, make, insulin. and you take a gene from the virus, whether it's human papillomavirus, which causes cervical cancer and other head and neck cancers, or the gene that codes for the surface protein of hepatitis B virus, and you put that into a plasmid, it's a small circular piece of DNA that you can then insert into like a yeast cell. So you grow up the yeast, and then while the yeast is growing up, it also makes that one viral protein. So that's how you make the hepatitis B vaccine, the human papillomavirus vaccine. So that was the sort of recombinant DNA era. Now we're in the next era, arguably the fifth era of vaccines, which is you actually don't inoculate the person with a whole killed virus, or you don't inoculate them with the weakened form of the virus, or you don't inoculate them with a single protein of the virus. You inoculate them with the gene that codes for the protein. So now the person makes the viral protein. And that is the leap of the mRNA vaccines or these vectored virus vaccines. You actually give the gene that codes for that. And so it's the genetic era of vaccines.
How different is the flu vaccine versus what we have now for COVID-19?
So there's a lot of different flu vaccines. You have sort of a flu vaccine that's pretty much just the two flu influenza surface proteins, and that's the standard shot most people get. There's also a nasal spray flu vaccine, which is a weakened form of the virus. There's also a recombinant DNA form of the flu vaccine called Flublok, which is just the flu virus hemagglutinin, which is that surface protein on the virus that sort of attaches the virus to cells. So there's a variety of different influenza vaccines.
How effective or not, or risky, let's go back to the 40s, were these vaccines? Was there a lot of risk?
Yes. Yes. I mean, I think there's still, we learn as we go. I actually have a book coming out in September called You Bet Your Life. The subtitle of that is From Blood Transfusions to Mass Vaccinations, the Long, Risky History of Medical Innovation. You learn as you go, and invariably that knowledge comes with a human price. And that is true right up to today, and it will always be true. You're always surprised. I mean, you look at these mRNA vaccines, for example, are phenomenal. They're remarkably safe and remarkably effective, but they're not absolutely safe. I mean, if you're between 16 and 30 years of age, about 1 in 30,000 people will get myocarditis, which is an inflammation of the heart muscle. That was not anticipated. With the Johnson & Johnson AstraZeneca vaccines, those vaccines cause blood clotting, including severe blood clotting in veins of your brain, which can be fatal. The fancy name for that is thrombosis, which just means blood clot, and thrombocytopenia syndrome, which just means low platelets. That was unanticipated. So you always learn as you go. There's never a completely risk-free choice in medicine. If something works in medicine, by definition, anything that has a positive effect can have a negative effect. You just hope that negative effect is very rare. But you always learn as you go. Always. I mean, I'm at the University of Pennsylvania. I mean, I don't know if you remember the Jesse Gelsinger story, but he was an 19-year-old boy, 19-year-old man who had a genetic abnormality, an enzyme deficiency. So he was given a gene therapy that ultimately killed him. And from that, you learned how to make better gene therapies. There was a gene therapy using something called retroviruses. HIV is a retrovirus, but there are a lot of sort of benign retroviruses. And, the early retrovirus studies were found to cause leukemia in people. You always learn as you go. I mean, the early heart transplant stories or kidney transplant stories, x-rays, people that were radiologists would invariably lose their fingers, and get cancer working, with early x-rays and antibiotics. There was the elixir sulfanilamide disaster for the polio vaccine. I think what most people, I'll give you two examples of what I mean by the polio vaccine. This is a perfect example. First of all, when Jonas Salk made his polio vaccine, the 5 companies stepped forward to make it, to mass produce it, to manufacture it. One company made it badly, so much so that they failed to fully inactivate the virus. One of them, Cutter Laboratories of Berkeley, California, made it badly. They failed to fully inactivate the polio virus. As a consequence, 120,000 children were inoculated with live, fully virulent, deadly polio virus, and thinking it was a polio vaccine, right? About 40,000 of them developed abortive or short-lived polio, meaning paralysis. 164 were permanently paralyzed, and 10 were killed. I think it was one of the worst biological disasters in this country's history. Nobody remembers that. And what you remember is this as ticker tape parades for Jonas Salk, and Jonas Salk was probably the most famous scientist at the time ever. But what people don't remember was the price that was paid for how to mass produce that vaccine. Actually, All the companies had trouble inactivating the virus. Another company, Wyeth, also made a vaccine that paralyzed and killed children. It's never easy. And when we did the big study, the big so-called Francis Field trial between 1954 and 1955, I mean, that was the biggest trial test of a vaccine ever done. Okay, ever. It was 420,000 children were inoculated with Salk's vaccine. 200,000 were inoculated with placebo, and 1.2 million children served as observed uninoculated controls. And when Thomas Francis stood up on the podium of Rackham Hall at the University of Michigan and said those three famous words, safe, potent, and effective, those three descriptors were on the headline of every newspaper in this country. Church bells rang out, synagogues had special meetings. I mean, department stores stopped while he made that announcement. Well, how do we know it was effective? We knew it was effective because 16 children in that study died from polio, all in the placebo group. We knew it was effective because 36 children were paralyzed in that study, 34 in the placebo group. I mean, this is particularly emotional for me because those children were my age. I mean, when that happened, I mean, they could have lived long, healthy lives as I have, but for the flip of a coin.
They didn't get it. They were part of the control group.
They were the placebo. Had they gotten the vaccine, they wouldn't have been in that situation. They could have been where I am, which is, living into an older age. But, there's a human price to be paid for knowledge always. And there's no getting around that. We'd like to think that we're at a point in science where, well, we know so much now that there's never a human price paid for knowledge. And that's never true. I think it's never going to be true.
So then talk to the audience about that calculus.
When you know enough. I mean, that's really at the heart of it, right? I mean, when Pfizer did its study of 12 to 17-year-olds for its vaccine, that was a 2,300 person study. Half got the vaccine, half got the placebo. There were 18 cases of COVID in that study, all in the placebo group. I'm sure that the parents in that study who by the flip of a coin were in the vaccine group were happy they were in the vaccine group because those children didn't have to suffer that disease. Now, I'm on the FDA Vaccine Advisory Committee. When basically the FDA then approved that vaccine or, authorized through emergency use authorization vaccine for the 12 to 17-year-olds, there were a number of emails that I got from people saying just what you just said. Was that big enough study? I mean, you did a study of 2,300 children, but you're now about to give it to millions of children. I mean, was that big enough? Shouldn't you have done at least the study the size of the adult study? Don't do 2,300, do 23,000. So you could do a 23,000 child study. And then instead of it being 18 cases of COVID in the placebo group, it could have been 180 children who had to suffer that disease and possibly be hospitalized or worse from that disease. When do you know enough to pull the trigger? That's where we are now with the vaccine for the 6 to 12-year-old. When do we're going to study it? It'll be studied in thousands of children. Probably not tens of thousands, probably just thousands of children. And then you will give it to millions. I mean, so when you say, I want to wait, I want to wait to see. There are no risk-free choices. There are only choices to take different risks. And your goal is to take the lesser risk. You could say, I want to wait till the first few million doses are out there. And frankly, Maurice Hilleman, who I consider the father of modern vaccines, said it best. I mean, he is either the primary inventor or primary developer of 9 of the 14 vaccines that we currently give to children. He was amazing, right? But what he said was, quote, I never breathe a sigh of relief until the first 3 million doses are out there, which is never going to be a pre-licensure phenomenon. That's only going to be post-licensure. Well, okay, that's fair. I think that's fair. I think people could say, look, messenger RNA technology or these vector vaccines, that's a new technology against a novel virus that has already had a number of surprising clinical or pathological observations. I want to wait till the first few million doses are out there. But I actually think that's an understandable thing to say. But the fact is, more than 360 million doses are out there. This vaccine has been given to half of the American population. This is not an experiment anymore. We know a lot about this, more than most any licensed product I can think of right now. So to continue to wait is wrong. And to get to the earlier point that you made, if you look at the history of vaccine development for the last 200 years, when there is a serious side effect or a fatal side effect, they invariably occur within 6 weeks of a dose. So this notion of, let me wait 5 years or 10 years, that is without precedent. There is no example of something coming up that much later.
Has there always been a anti-vaccine kind of movement in the country or around the world? Has that always been with us?
Yeah, I mean, the anti-vaccine movement was born of the first vaccine, which was Edward Jenner's smallpox vaccine. I mean, there was a cartoon that was made by James Gilray in 1804. And in that cartoon, what you see is Edward Jenner, the inventor of the smallpox vaccine, sort of inoculating a woman who's looking very fearful. And the reason she's looking fearful is that if you look at all the people that are surrounding her, they're developing sort of, floppy ears and snouts. They're starting to take on cow-like characteristics, bovine characteristics. So the thinking was, if you get this vaccine, you're going to develop bovine characteristics. Well, I would argue, we laugh at that cartoon today. We could, because we should. It's funny. I would argue some of the claims made about vaccines today are just as biologically sound as that. I mean, that vaccines cause autism makes just as much sense as that you would develop floppy ears if you got a smallpox vaccine. So I don't think that's ever changed.
Let's talk about modern day COVID-19 and those that are either paranoid or that they're just against getting the vaccine or think it's bad. I don't want to bucket everybody into one ideology or one thing. So, I mean, there must be a range of concerns about the vaccine. But was it the anti-vaccine movement prior to COVID that fueled the movement now? Is it that same kind of cohort, or has this morphed into something else entirely because of the political environment? Or was it the speed of this particular getting this vaccine to market? Or is it just this big soup, combination of everything I just said?
I would have said that a year and a half ago, there was no politics to the anti-vaccine movement. On the right, it was this libertarian government off my back, don't tell me what to do. On the left, it was the sort of all things natural. I'm just going to lead a clean, healthy, lifestyle where I'm not going to, I'll avoid gluten and I'll avoid bisphenol A and I'll avoid, casein and I'll avoid anything made with dolphins and I'll be healthy. So, the sort of the Whole Foods crowd. So the Whole Foods crowds versus this kind of Rand Paul libertarian crowd. Not true.
Yeah, I like Whole Foods, Paul. Come on.
You can like Whole Foods and be vaccinated, but that's not true now. There is a politics to this, and it is a libertarian politics.
So you think it is you think it is a mostly political?
I think that's the anti-vaccine people are still always making the arguments they make, which is these non-fact-based arguments. The vaccine will alter your genes, the vaccine affects fertility, the vaccines, the vaccine causes the disease. I mean, all the usual nonsense that the anti-vaccine people bring up, they still bring up. But this is the first time I've seen this more as a don't tell me what, it's my personal liberty. It's my civil liberty not to get a vaccine, which, by the way, isn't true. I mean, I think if I step on a rusty nail and I go to the doctor and they say, would you like to get a tetanus vaccine? And I say, no, that's a personal choice. I mean, if I end up getting tetanus, no one's going to get tetanus. For me, it's not a contagious disease. This is a contagious disease. This is a decision you're making for others. This is the equivalent of saying you don't want to stop at an intersection because the stop sign is a violation of your civil liberties. Story after story of people who don't get a vaccine, who then proceed to infect their pregnant wife, who then goes to the hospital, goes to the ICU, gets ventilated, delivers their baby prematurely, and often fatally. And that's the story. It's not a decision you're just making for yourself. So therefore, it's not a civil liberty. And this is all the right. That's all stuff. I mean, you see it now with DeSantis and Abbott in Texas. It's all this kind of, that's what it is. It's we're going to stand up to a government that's making us do things like put masks on our children when it's the only way you can protect children less than 12 years of age.
I mentioned it briefly before we started that I can't find my school record. There's not a national repository of the vaccines that I had when I was a kid, but there must have been 7 of them that I took.
Yeah, so you would have gotten the DTP vaccine, diphtheria, tetanus, pertussis vaccine. You would have gotten the polio vaccine. You would have gotten the smallpox vaccine. The measles vaccine came in 1963. So you probably eventually got the measles vaccine. You eventually got the mumps vaccine. You probably eventually got the rubella vaccine. I was born in 1951. So I only had 3 vaccines in my childhood record, which was diphtheria, tetanus, pertussis, smallpox, and polio.
My parents were anxious to make sure I had these vaccines. They didn't want these diseases. What the hell happened?
Polio was a big deal when I was little. I mean, I had a unfortunately poor operation that was performed in my right foot because I was born with a congenital abnormality in my right foot. So the surgery, which should have never done, was done badly. But I ended up in a hospital called Kernan's Hospital for Crippled Children. That was back in the days when you had words like crippled and feeble-minded in the name of hospitals. And so I was in a polio ward for about 6 weeks. And I vividly remember that ward. Vividly. I remember the iron lungs. I remember children like me.
That's it, Paul. This is not visual. We don't have bumps on our faces if we catch the disease. I'm guessing it's not visual. We don't see people falling over.
No, see, but this pandemic certainly should have gotten our attention. I mean, it's certainly brought us to our knees. Polio was the enemy. And so what did we do? We gave our dimes to the March of Dimes, which created millions and millions of dollars that paid for the research of Jonas Salk and Albert Sabin, that paid for the production of that vaccine, that paid for the administration of the vaccine, much as the government has done now. But then polio was the enemy. Polio had no friends. Polio virus had no friends. That's not true now. SARS-CoV-2 has a great many friends. I mean, vaccine denialists, science denialists, conspiracy theorists, a lot of these elected representative pundits on national television. I mean, there are a great many people who stand up for SARS-CoV-2. I would like to see a little cartoon character of SARS-CoV-2 going up to Ron DeSantis and putting out his hand and saying, thank you for your continued support, because that's what he's doing.
You would think the weight of our past and our history would have pushed us through this, but something has fractured, and I don't understand it. So how safe are these current vaccines? And let's address COVID-19 and then the Delta variant. And by the way, I know this is, as soon as you and I talk, it's changing, right? So what do we know right now, Paul?
Here's what you know. You know that I think it's actually remarkable that within 11 months of isolating this virus in January of 2020, we had 2 large clinical trials of a novel technology, messenger RNA, that was remarkably effective and remarkably safe. Not absolutely safe, but it's pretty darn close. And what you can say now with confidence is the vaccine was made against that so-called ancestral strain that first appeared in Wuhan. Well, that's not the virus that left China. The virus that left China was the first variant, the so-called D614G variant. That was eventually replaced by the Alpha variant, which was eventually replaced by the Delta variant. What you can say about these vaccines is all of them remain very, very effective, like in the mid 90% range at protection against severe critical disease, the kind of disease that causes you to go to the hospital or go to the ICU or die. It's remained very effective against those. When that changes, when it looks like that the percentage of people who, despite being fully immunized, are nonetheless starting to get hospitalized or worse, then we'll talk about booster dosing. But for right now, we don't need a booster dose. The vaccine was remarkably effective for people over 65. It was remarkably effective for people who had a variety of comorbidities like obesity or type 2 diabetes, et cetera. When I'm on the FDA Vaccine Advisory Committee, we were told that we could reasonably approve this vaccine through emergency use authorization if it was at least 50% effective with a lower confidence interval of 30%. Okay, it was 95% effective and safe. I don't know what people want. Anybody who looks at the data would get this vaccine. When people say they've chosen not to get it, there is no good reason not to get this vaccine. Unless you've had a severe allergic reaction to the first dose and you don't want to get the second dose, that I get. That's the only good reason not to get a vaccine. It's painful. And we're so careful about sort of not violating someone's physical, personal liberties. This isn't a personal liberty. It's not your right as an American to catch and transmit a potentially fatal infection.
Are there people who should not get the vaccine with some comorbidity or underlying issues?
There are people who aren't going to respond to the vaccine. I mean, people who are on cancer chemotherapy, people who have bone marrow transplants, I mean, they're pretty densely immune compromised. They're not going to make an immune response. It's not unsafe.
It's not going to boost it enough to help.
It's not going to cause an immune response at all. I mean, but it's not unsafe. I mean, the messenger RNA will make that it enters cytoplasm of your cell. It'll make that SARS-CoV-2 spike protein for a few days and then stop. So even if you don't have an immune system, it's not dangerous. So, there are people in this country, and it's basically 2.7% of the population is immune compromised. That's about 9 million people that depend on the herd to protect them.
Do we know if the majority of what's out there now is Delta?
Yeah, like 93% of the circulating strains are Delta. Delta's taken over.
So the vaccines, they would help inoculate you or prevent you from getting COVID-19, I think, right? But now with Delta, it's a matter of, hey, this is going to prevent you from getting very sick.
I think that, and that's always been true. As a general, these kind of vaccines are generally not as good at preventing asymptomatic infection or mildly symptomatic infection. We should stop calling those breakthrough infections. Those aren't breakthrough infections. That's what you would expect. A breakthrough infection is got a vaccine, fully vaccinated, nonetheless, I've been hospitalized. That's a breakthrough infection. And we should really be careful about the terms, because if we're expecting these vaccines to protect us against asymptomatic infection or mildly symptomatic infection, we're going to be really disappointed, because that's not the way these vaccines work.
So it's mainly getting very, very sick.
I mean, it still largely protects you from that, but it's not as good about protecting you from the milder range of the spectrum as the severe range.
If somebody, in your opinion, had COVID, they've got some form of, they have antibodies, right? Should they still get the vaccine?
Yeah, so there was a study done looking at people who were naturally infected and survived. If you've been naturally infected, you are better off being boosted with the vaccine than if you've been naturally infected and you aren't boosted with the vaccine. You're more likely to be protected against basically mild infection if you've been boosted than if you haven't. So it's worth getting a booster.
Why did the FDA, why are they taking so long?
So the studies are currently being done in the 6 to 12-year-old. When those data are complete, they will be submitted to the FDA, and the FDA will then send it over to our committee to review it. I haven't heard about setting aside a date yet to do that, so not in the near future. Hopefully it'll be by no later than late fall, because as you move into the cooler, drier months, late fall, early winter, this virus is going to be spread more easily. In terms of full approval, that should happen, I think, by no later than mid-September. There is the difference between emergency use authorization and full approval is really more psychological than anything else in terms of the consumer. When we approved the vaccines through emergency use authorization in December, we could say that, I mean, those trials were as big as any pediatric or adult vaccine trial. There's no difference there. 30,000 for Moderna, 44,000 for Pfizer. That's the size of any trial, any typical vaccine trial. And the length of safety follow-up was the same, 2 months after the last dose, because any safety issue that has been historically a problem occurs typically within 6 weeks of a dose. So the only difference was efficacy. I mean, when we said these vaccines were effective back in December, we could say they were effective for a few months. That's all we knew. And so, but you're not going to do a 3 or 4 year trial in the midst of a pandemic. You're going to say, okay, it's at least this effective now. I suspect it's going to be this effective for a while, and let it go. So to be fully approved, you really need 6 months of data. So there's that. But the bigger issue, and the reason it takes longer, is when the FDA licenses a product or approves a product. They approve not just the product, but also the manufacturing site and the process. And so every aspect of the manufacturing has to be validated via these protocols. I mean, when I was part of a team at Children's Hospital Philadelphia that created the rotavirus vaccine, that validation process took a year. Now, they're working around the clock at the FDA to get that done, and I think it will be done by mid-September, hopefully. But that's the difference. But from the standpoint of the consumer, it's not like, once it's fully licensed, you can say, okay, now I know it's safe and effective. There's more than 360 million doses that are out there already. You can say it's safe and effective now.
Well, because I think some people may be using that.
Oh, they are. And I think it's a straw man argument. I think that even when it is approved, they're going to come up with another argument.
So what you're saying is this FDA process with the vaccines is a normal process. There's nothing unusual about it taking this long. Is that right?
I mean, this is much faster than usual. The time it takes to get a vaccine license, once submitted, is about 10 months. I mean, here it's much faster.
Now, the vaccines alone won't stop the variants, or will it?
Yes, if we had 90 to 95% vaccination rates in this country, we would dramatically slow the spread of this virus. We wouldn't be talking about masking. We wouldn't be talking about booster dosing. We wouldn't be talking about getting life back to normal, because life would be back to normal. I mean, when we were vaccinating months ago 3 million people, giving 3 million doses a day, if we kept on that pace, we would be at 85 to 90% population immunity. But we didn't. We fell off because we hit a wall. We hit a wall of 25 to 30% of this population said they didn't want to get vaccinated. No, thank you, they said. And so what do? You do what we're doing, basically, which is to compel vaccination through mandates, mostly at the private sector, to a lesser extent at the federal level. I just think sometimes you have to compel people to do the right thing. It's sad. Anybody that looks at these data would get this vaccine, but some people are just stubbornly, willfully ignorant about this vaccine. Sadly, I think that it's not people's right to catch and transmit this virus. I'm sorry. I'm sorry that they have to be compelled to do the right thing, but so be it.
Is there any kind of evolution of strains that evade a vaccinated population?
Usually it's more of a selection. So the pneumococcal, see, that's a bad example. I mean, so pneumococcus, there's many different types of pneumococcus. The initial vaccines had, either 7 of those types or 13 of those types. Now it's 15 or 20 of those types, but there's more than 90 of those types. And so what will happen is, as you eliminate the other ones, then the ones that you didn't eliminate start to at least emerge. So there's that. But measles is a good example. Measles, like this virus, like SARS-CoV-2, is a single-stranded RNA virus that mutates. We've had a measles vaccine since 1963. I mean, we have almost 60 years of a measles vaccine, and that virus has not mutated away from the vaccine. I mean, you look at Tucker Carlson. This is my favorite, right? Tucker Carlson gets on national television, and Ron Johnson said the same thing, and said 3,300 people have died following this vaccine. That's what he said. Okay, now think about this for a second, because that was reported to the Vaccine Adverse Events Reporting System. In this country, 750 people per 100,000 per year die. They do. That's the death rate in this country. So that's roughly 2 per 100,000 per day. If you vaccinate 100 million people, that's 2,000 people should die within 24 hours of getting the vaccine, 4,000 within 48 hours, 10,000 within 5 days. So when he says 3,300 people have died, that's what you'd expect, unless the vaccine confers immortality, which it doesn't. It only protects against SARS-CoV-2 infections. So it's just, you listen to this and you think, I mean, this isn't exactly, theoretical physics. It's just pretty much just math. And it's just hard to watch. It really is hard to watch.
Of the vaccines, Pfizer, Moderna, Johnson & Johnson, are there others soon to be on the scene?
Yeah, I think Novavax is the more traditional kind of purified protein vaccine. So you actually give the viral protein the way we do hepatitis B or human papillomavirus. So I'm not sure why we haven't heard from them. Certainly they were moving along. I think they've had production problems. And my theory on these things, even though we have more than enough vaccine, obviously, for people in this country, because we're basically throwing away vaccines because we have more than we need, I still think there's 195 countries in this world. Many have not given a single dose of vaccine. I think you can assume this virus is going to be with us for a while. So I think we're going to need to have a highly vaccinated population for years, if not longer. And so the more we learn about these different vaccine approaches in terms of their capacity to protect against variants, in terms of how long immunity lasts, the better we are. So that's good. I mean, think about it. We still give a polio vaccine in this country every year to children. 90% of children in this country get a polio vaccine every year. We haven't had polio in this country since the late 70s. Why are we giving a polio vaccine? Because polio still exists in Afghanistan, it still exists in Pakistan, and pretty much just those 2 countries. Nonetheless, there's no doubt in my mind that with international travel being what it is, that polio occasionally walks into this country. If you let your guard down, you're going to see polio come back.
So let's say you're my uncle. I haven't been vaccinated yet. Uncle Paul, which vaccination should I have? Does it matter?
Doesn't matter. They all just whatever you can get. If you look at the so-called cellular immunity, T cells, B cells, you get a much better cellular immune response, which predicts longer lasting and more complete protection with the second dose. I think that about 8% of this country who've gotten the first dose haven't gotten the second dose yet. Now you can just pick it up where you left off. You don't need to start all over again. But you need to get that second dose.
I think I was told there was a window of 40 days or something from the first vaccine to the second. No?
You can pick it up whenever you want. Yeah.
Oh, okay. And you mentioned this earlier, but let me kind of pin you down here. Am I good for a year, or we don't know yet? You'll think this will be a yearly shot, you think?
I would be surprised at that. I mean, I probably should never make predictions because we're always wrong when we make predictions about this virus. I think it's going to be every few years if I had to make a guess. But again, we'll see.
And then as we wrap this up, what do you think we're at peak Delta here? Are we following patterns that other countries have had, or are we an outlier in some way?
Well, we can do better with a higher percentage vaccination. The UK has a somewhat higher percentage vaccination. They're like in the close to 60% of the population vaccinated. We're like 50%. They're close to 80% for at least one dose. We're closer to 70%. So they're a little better than we are. But I'm not sure the reporting is as good as ours, frankly, in terms of hospitalizations and deaths per day. India actually had a decline, actually, in Delta, but it's because they really locked down. So it's really vaccination and behavior. Those are the 2 things that determine spread, I think. And our behavior this year is obviously much worse than last year. Look at last year. I mean, people didn't go back to school. When they did go back to school, everybody was masked, everybody was social distance. We were really careful. This year, we're not.
Some of that I understand just because we have been locked down and people were anxious to get out. And we thought we were kind of coming out of this to a degree. But I haven't traveled in a couple of years, Paul. I'm going to get on a plane at the end of this month. Is the fall going to be, do you anticipate if nothing changes between the vaccinated and unvaccinated, are we going to have a rough fall?
I fear we are. I mean, Delta's contagious. I mean, as we move to fall and winter, it spread more easily. There's still communities that are highly under-vaccinated. I hope I'm wrong, but I really fear for children going to school where they're not allowed to wear a mask. For the children less, well, that's the only weapon they have. You can't take that away from them. If I had a 10-year-old who was going to school, I would really hope there was a mask mandate. I live in Philadelphia where there's a mask mandate. And not only that, there's a mandate for teachers to get vaccines. There's certainly a lot of support, including with the teachers' unions, for teachers to be vaccinated. I mean, you just saw in Broward County, there were 4 educators that died. One of them, the vaccination status was unknown. The other 3 were unvaccinated. What are they thinking about? This was tragic last year when people would die from this virus. This year, it's all the more tragic because it doesn't have to happen. 620,000 people have died. I mean, really, it's a pandemic. It's a plague.
Paul, thank you so much. And where can people find you or follow you?
I do have a website, which I can never remember. I think it's paul-offit.com. I think it's what it is.
And I'm gonna link to everything in the show notes. And you're also on Twitter.
I am. Pretty rarely tweet, but yeah, I'm on Twitter. It's true. I think I'm at Dr. Offit.
I'm following you, so
all right, good.
I trust you. So yeah, as things change, please post. And thank you again for coming on and helping me get the message out.
Thank you. It's my pleasure. Good luck.
Well, that's a wrap. Thank you for listening. If you enjoyed it, do share it with your friends and on your social platforms. Big thanks to Sam Williams, my audio guy, and the beautiful bumper music you're hearing is Michael Petrovich's Bella Luna. For all my show notes or resource links, visit larryweeks.com, and we will talk again soon.